This webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally, and we are amongst the largest closely held pharmaceutical company in India. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and Heathrow Healthcare has Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Pioneering in quality and innovation, Heathrow Healthcare has distinction of bringing four biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneer in antivirals, offered to the patients Oseltamivir, Favipiravir, and Remdesivir, because of which they received an award in August 2020, Award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Jog sir as our moderator, and Dr. Ketan Shah and Dr. Ravindra Chopra as speaker. Welcome Dr. Jog, welcome Dr. Shah, and welcome Dr. Chopra. Dr. Pramod Sok sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI, CSO 2016 to 19, Chairman Mini SP Module IIP, and author of book Cophology. Welcome, Dr. Zog. Dr. Ketan Shah, sir is President Surat Pediatric Association 2003, National Trainer ATM PSPP ASK IIP CPIDC. How do I investigate National Antibiotic Practice, National TB Module, Rapid Module, National Secretary Pediatric Rheumatology Chapter 2005 and 6, Organizing Chairperson National Rheumatology Meet 2006, EC Member Gujarat Pediatric Association 2014-2019, EC Member ID Chapter 2013. Welcome, Dr. Ketan Shah. Dr. Ravindra Chopra is MBBS MD, sir is Chief Pediatrician and Director, Muskan Children Hospital, Surat. Welcome, Dr. Ravindra Chopra. And with this brief introduction, I hand over the session to Dr. Pramod Zug for further deliberations. Over to you, sir.
Thank you. Thank you, Dr. Prashant. And today we are going to have a discussion on influenza and oseltamivir. Now, the most important thing is that the monsoon in various parts of our country is quite active and lot many viral illnesses are prevalent. So we are witnessing RSV, we are witnessing influenza, we are also witnessing mosquito-borne illnesses like dengue, and the pediatricians are really overworked and bogged down by the work. At this particular juncture, it is necessary that our colleagues know about all these viruses and also other respiratory infections so that there is no confusion while managing the cases with different kinds of infections. Recently, a child came to the clinic and the child had typical viral infection with runny nose, red eyes, and the child had, cold and cough with very mild fever. And then I told the parents that this is likely to be viral. So the small little child also started imitating me, and there was a doll in her hand and started telling her, viral hai, viral hai, viral hai, fikar mat karna, don't worry. So even small little children these days, they know that there is something like a viral and it is something not to be worried about. But the scenario has changed. Whenever someone says viral, I always start thinking of COVID-19, I start thinking of H1N1 and adenoviruses, which, continue to have prolonged course and so on and so forth. So viruses now are not that simple. And it's probable that, after COVID, there is something called as immune debt. People and children, they did not develop immunity against many of these viruses. And that is why, if you agree with me, after the downfall of COVID, somewhere after mid 2022, there were waves of different viruses. Like, once we saw RSV upsurge, once we saw hand, foot, mouth disease upsurge. Then at certain places where measles immunization was on the lower side, we could even see rise in the cases of measles. So all probably was because of the less or absent immunity against these viruses. and we have been witnessing even older children getting affected. So that immune debt is, at the back of many of these viruses which are surfacing up in the post-COVID era. And then recently there was a serious child with, influenza, which came to the OPD with fever, cold, cough, and progressive breathlessness for 3 days. The child was tachypneic and hypoxic, and the X-ray and the clinical picture was suggestive of ARDS. The child was admitted to the PICU, ventilated, was given oseltamivir and supportive treatment, and H3N2 was positive from the throat swab. He was ventilated for 3 days, and then the child improved. Now, at that time, we were confused, because initially we did not know whether this is bacterial or viral. Our colleagues also get confused whether if it is viral, which is that virus, whether it is something like a benign virus like rhinovirus, adenovirus, or influenza. If it is influenza, whether this is H1N1 or H3N2, and whether I should start oseltamivir upfront. So in a previously healthy child presenting with cough, cold, and fever, and progressing over 3 days, just as I told you in that case, whether the treating physician can prevent the progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront in the flu season. So all these are points which our colleagues would like to know. So in today's discussion, we will discuss most of these points, and I am fortunate to have Dr. Ketan and Dr. Ravindra to discuss all these points threadbare. So I hand over the proceedings to Dr. Ketan. In the initial part, Dr. Ketan and Dr. Ravindra will discuss most of the aspects of influenza, followed by some discussion wherein we will have questions from our audience. Thank you. So, Dr. Ketan, you can take over and start with the discussion with Dr. Ravi.
Thank you, sir. Thank you for a kind and brief introduction. Thanks for a brief introduction about the monsoon disease also. We are thankful to Hetero Company for giving us this opportunity. As Dr. Jog sir has informed us, we'll be discussing about the flu disease, the role of oseltamivir, and how does it work in our clinical scenario. The main content of talk would be healthcare challenges in monsoon and their diagnosis, influenza and its complication, clinical evidence of oseltamivir, guideline recommendation for empiric use of oseltamivir. Dr. Jog sir has been always rational to treat the patient. He does not allow J for jugglery. So whenever he was a national president, he insisted that there has to be a rational practice. He even say O, opportunity to identify, and G for good work. So JOG, Jog sir, stands for avoid jugglery, identify influenza, get an opportunity to identify the organism, and do a good rational work, especially whenever there is an epidemic of the disease. So in monsoon, we get influenza-like illness, H1N1, severe acute respiratory illness, and COVID-19. These are the challenges of healthcare in monsoon. India and flu disease. Do we know about the cases of influenza in India? When does it occur? And what is the correct time to vaccinate? Previously, few years back, people and the doctors was telling कि फ्लू में कुछ नहीं है, फ्लू जैसी कोई बीमारी इंडिया में है ही नहीं. But now we have a concrete evidence. This is the graph which has been taken from Purple Book of Indian Academy of Pediatrics, which is the vaccine book, and all pediatricians know that this is a Bhagavad Gita for us, so far so vaccination is concerned. This is taken from page number 324. This chart says that from 2014 to 2019, every year between January to April, we get the peak of influenza. The number of cases has increased to 20,000. And the second peak is between June to October. The highest peak comes into the August and in the February. So this is every year we get these peak season. There might be some seasonal variability also in each state. This chart shows that the global burden of disease in 2017, hospitalization was 5,88,000 for influenza-like lower respiratory tract infection, and the death report was 26,000. Again, from the Purple Book, the number of cases of influenza in 2017, they were 38,811 and 2270 death. And in 2022, 12,000 cases has been reported and 399 death. These data are up to November 22. So we can see that a huge chunk of disease, these are reported positive cases. And majority of the time testing has not been done because of financial constraint. So incidence is too high to go. Looking to the Indian data in various studies, it has been found that 5 to 10% of all ARI are due to influenza. 10 out of 100 children per year, they suffer from influenza. In various studies, it has been shown that out of 1,000 children, 178 to 180 children per year below 1 to 2 years, they are affected from influenza-like illness. Influenza-associated respiratory tract infections are 33 to 44 per 1,000 children per year. In 2009 pandemic, 22.8% positive cases of influenza were seen, and in 2015 up to March, more than 30,000 cases has been reported and almost 1,800 deaths has been found because of influenza. So looking to these statistical data, it is beyond doubt that influenza does exist. Incidents are very high. Mortality is also comparatively high. In northern India, the peak comes between January to March. Central India, it is July to September. Southern India, September to November. Usually we get peak in winter and monsoon, and the pattern of circulating strain is quite variable every year. This is again the pictorial presentation of number of cases of influenza in India. The last column bar is 2019. 28,000 cases has been reported in 2019 and almost 1,200 deaths has been found in influenza disease. So the chunk of disease is very high in India. Just to prove this was the one study which has been done in Chennai. Dr. Ravi, can you highlight on this study? Over to you.
Thank you, Dr. Ketan. And thank you for summarizing the epidemiology of influenza very well. And as like in the recent days, we know that influenza does occur in our country. Influenza has a seasonality. It has multiple peaks in different parts of our country, in northern hemisphere, southern hemisphere, and middle part of India. But this study was a path-breaking study which actually revealed about the seasonality of influenza. So this study was done in Chennai, Tamil Nadu. It was a 7-year cumulative study done at the Department of Virology in 2019 at King's Institute of Preventive Medicine and Research Center. And in this study, 36,670 specimens were subjected to influenza analysis throughout the year. So continuously, these samples were collected and analyzed for influenza virus over the period of 7 years. So what did this study tell us? Apart from the influenza positivity, there was a seasonality. So in this southern part of India, the influenza positivity, it is started with the onset of the monsoon and it peaked during the post-monsoon months, which we also see in our practice and day-to-day practice. Though northern hemisphere people might see it in the winter peak. So this was a study that revealed that there is a definite seasonality even in our country.
Thank you, Dr. Ravi. So far, so we had a discussion that influenza does exist in India and it has been proved by various scientific studies. The flu virus, we all know, it is one of the most common infectious disease caused by influenza virus, highly contagious airborne disease. It occurs in seasonal epidemics and manifests as an acute febrile illness. The disease severity varies from a very mild to very severe illness, and serious outcome had been seen, as Dr. Jog sir has initially said that recently they had a child who has been on the ventilator for respiratory compromise. And there are various types of influenza virus. Dr. Ravi, can you highlight what are the types of influenza virus and what is a drift and shift? Over to you.
So, influenza, as we all know, is a RNA virus, and all RNA viruses are very notorious. They have a very high replication rate. They are bit higher on mutating, and they have a lot of antigenic variation. So, influenza is one of them. And depending on their structure, on their nucleoprotein and M capsid capsular protein, these viruses are classified in four groups: A, B, C, and D. Influenza A is further subtyped depending on heme agglutinin and neuraminidase, which we will discuss. So, influenza A virus is commonest virus in the influenza series. It causes frequent epidemics because of the minor antigenic variation, and it does cause periodic pandemics also, which we have already faced in our swine flu pandemic in 2009, and there were epidemics of Spanish flu, Asian flu. So these were epidemic, all were caused by influenza A virus. So this influenza A virus is most significant virus for our day-to-day clinical practice. Second one is the influenza B virus. So it is a very stable virus, though it infects only human and causes local epidemics. It has two lineages, Victoria and Yamagata, but it does not vary. So they are quite stable. Influenza C virus, it infects human and swine, and type C causes generally a very mild respiratory illness and generally not very well studied, not very well encountered in our practice because of the minor illness. And influenza D virus is mainly a disease of cattle. So currently circulating viruses we do see in our practice right now in Surat we see most of the H1N1, and few months back we were getting a lot of H3N2 also, as sir has already depicted one case of H3N2. So why these vaccine keep on changing? So there is a, because of RNA virus and their nature, there is a constant drift and shift. Drift is a kind of a minor readjustment in viral genome, which makes it little antigenically difficult, and it may fool our immune system and can cause infection again and again every season. So that's why we have an influenza vaccine, a different vaccine with every season. And shift is a kind of a major reassortment of the viral genome. So whole of the virus is like a new virus, as we had in our swine flu epidemic. It's a entirely new virus. So this is a kind of a shift mutation, which is a major mutation, and it becomes a health hazard as it causes pandemics.
Thank you, Dr. Ravi. Very nicely elaborated the various types of influenza and the concept of drift and shift. Flu virus spreads very fast. It can spread it to other people up to about 6 feet away also. It spreads mainly by droplet. When people with flu cough, sneeze or talk, the droplet goes into the environment and it enters into the another person either through the oral cavity, nasal cavity, or through the hand contact. People should stay away from the affected person and stay home if they are sick. It is also important to have a hand wash technique to prevent the spread of the disease. Most healthy adult and even in the pediatric patient, before the onset of symptoms, they are contagious. And once the disease is symptomatically cured, even up to 7 days, they can shed the virus. So any sick child should take at least 7 days leave from the school to prevent the spread of the disease. In this season, we get varieties of respiratory symptomatology. We divide them into influenza-like illness, H1N1, SARI, and COVID-19. Although everything is overlapping, but in this table, there is some minor difference has been highlighted. Dr. Ravi, can you shortly elaborate what are the differential or different presentation of each disease? Over to you, Dr. Ravi.
So we classify them under ILI. ILI is a kind of a terminology which is used for any influenza-like illness. So any respiratory infection which is associated with fever for more than 100.4 degree Fahrenheit with sore throat and respiratory symptom. So this is ILI is a broader category which includes H1N1, SARI, COVID, and the diseases mimicking influenza. So ILI generally includes fever, maybe moderate to high grade fever, myalgia, cough, lack of energy, sore throat. These are the cardinal symptoms of all ILI. But if you differentiate it in different ILIs, like H1N1 is predominantly respiratory distress and breathlessness, which is a common scenario in H1N severe H1N1. Whereas SARI, we always have respiratory problem because it's a kind of severe respiratory infection, and many of the patients need assistance and ventilation also. Then systemic signs like headache and body ache are also very common in H1N1 as well as SARI. But what is typicality of COVID-19 is mainly, along with the respiratory involvement, there is a generally loss of smell and loss of taste. Not in all cases, but whenever it is there, they are quite diagnostic or it leads to the diagnosis of COVID-19 uh, because other illnesses less often have this kind of symptom, whereas COVID-19 has more of these kind of symptoms. And other systemic involvement like GI involvement and all other systemic involvement is more common in COVID as compared to H1N. So these are in nutshell, like we can have some clue, but practically it is very, very difficult and we have to many times resort to some diagnostic tests and follow-up of the child.
Thank you, Dr. Ravi, for elaborating the differential diagnosis on clinical ground. Yesterday only, I had one adolescent. She's 18 years, came with fever, cough, and specifically she told me that, sir, there is a loss of smell and loss of taste. She had a respiratory distress. We suspected probably COVID or influenza-like illness. Child is hospitalized. However, due to financial constraint, diagnostic test has not been done and she is improving now. There are always some warning signs whenever you get any patient. This has been taught to us in the PALS course. Same way, any respiratory illness coming to you with a fast breathing, troubled breathing, cyanosis, irritability, dull child, tachycardia, poor peripheral perfusion, or maybe convulsion, not able to drink or eat anything. These are the warning signs of any respiratory illness. We consider these as an impending respiratory failure. Even in adult, you get difficulty in breathing, exertional dyspnea sometimes, there is a pain in the chest, you have a confusion, sudden dizziness, fever, irritability or drowsiness. These all are warning signs of any of the respiratory illness, and influenza can come with all these sign symptoms. So when you suspect it clinically that this is an influenza-like illness, you have a patient who is walk-in patient, you have a patient who is in ICU, you need to diagnose it. What is the etiological agent? Over to you, Dr. Ravi. Do we have any diagnostic test available for influenza disease?
So in our routine OPD practice, it is mainly a clinical diagnosis, and many of them we just label as ILI, and we will come under this kind of a classification of viral disease like category wise. So the category A and B do not require any diagnostic test. but we have some diagnostic tests to confirm influenza. One is a rapid antigen test, which is not very standardized and nowadays not used. The most common test we use is a PCR test, RT-PCR test. It can be in the form of a non-typable kind of a test, which we call it as a flu panel test, which is little cheaper as compared to the typified PCR test, which is a part of multiplex PCR or biofire panel. So this is most standardized test, and this subclassifies the virus also. Then for research purpose, we can go for a viral culture test, which is done at the various virology institute. And theoretically, there is a rising antibody titer against influenza. But mainstay in the chunk of the cases, the diagnosis generally remains to be clinical, and we don't tend to subject our patient to diagnostic test in category A and B. Talking about complications, flu is a primarily respiratory disease, so it affects the adjacent respiratory system and worsening of the respiratory diseases. So there can be a flu pneumonia because of virus, secondary bacterial infection leading into like pneumococcal pneumonia or staph pneumonia, bronchitis, bronchiolitis. Sometime croup also can be seen with influenza virus. Then other adjacent respiratory system involvement like in the form of otitis media, sinusitis, rhinitis. These are also one of the respiratory complications. Then other system involvement in the form of myocarditis can also be seen. Muscular involvement is also quite often seen in influenza patient in the form of myositis and rhabdomyolysis. Then one dreaded condition which we used to see previously more often is a Ray's syndrome, and is kind of a hepatic and acute encephalopathy because of use of NSAIDs, aspirin, in influenza patients. So this we less often see in our day-to-day practice. And in adults, the influenza virus can be the major causative organism for worsening of the underlying diseases like asthma, COPD, chronic renal failure, diabetes, chronic heart diseases. So this can lead to acute worsening of these conditions and sometimes lead the patient into intensive care unit.
Thank you, Dr. Ravi. You nicely elaborated the diagnostic test, its availability and its utility, and the complications of influenza. Now, we will go to the management of influenza. The main junk would be, or main key interest would be, when and how to use oseltamivir. Whenever the influenza patient comes to us, as Dr. Ravi had told us, we divide them into category A, B, and C. A is a mild disease, B is a moderate, and C is a serious disease. When you have a A category of patient, just a supportive treatment, bed rest, oral fluid consumption, cough suppressant, round the clock paracetamol, and as per requirement, NSAID to control the myalgia. Most patients would recover within 3 days. Malaise may persist for weeks together. Maybe 2 to 3 weeks, patient would feel that he is not okay. Weakness लग रही है, tonic चाहिए, bottle चढ़ा दो. ये सब बातें आती रहती हैं. And in severe cases, you may require hospitalization. For antiviral drug, we have a two category of drug. One is a neuraminidase inhibitor. Another is adamantanase, or called as a M2 ion channel blockers. Neuraminidase inhibitor, they block the viral neuraminidase enzyme. This is critical in releasing viron from the infected host cells. These drugs are active against influenza A and B, and the prototype, well studied, is oseltamivir. Zenamivir is a part of the neuraminidase inhibitor, but it is not very well studied and very well proved. Same way, adamantanase, they interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. Active only against A type of virus, and the drugs are amanitin and remanitin. So out of these all four, oseltamivir has been well studied and well proved drug for influenza disease. Oseltamivir is a potent and selective inhibitor of neuraminidase enzyme of A and B virus. It is a prodrug. It is converted into oseltamivir carboxylate in the liver. It inhibits viral replication and reduces its pathogenicity. It prevents further spread of infection, and it is effective against all strains of A and B, which includes avian H5N1, swine origin H1N1, and H9N2 strains also. This is some pictorial presentation. How does the oseltamivir works? The upper part shows a normal replication of the virus. There is an enzyme neuraminidase, and there is a release of new viron, and the viral multiplication goes on, causing viremia, release of toxins, and immunological phenomena. But if we use a neuraminidase inhibitor, the virus replication is halted, new virus is not formed, and it will not attach to the cell membrane, thus preventing the spread of virus or preventing the viremia. It was the first oral neuraminidase inhibitor which has been approved in more than 100 countries. FDA, CDC, American Academy of Pediatrics, and even the Indian government has approved its use. This is the dosage and recommendation of oseltamivir. It is available in 75 milligram capsule and a syrup, which is a 12 milligram per 1 ml. It is used for the treatment and for chemoprophylaxis. Chemoprophylaxis is once a day for 10 days, and treatment is twice a day for 5 days. The dose as mentioned in the table, for adult it is 75 milligram BD. For children less than 15 kg, it is 2.5 ml BD. 15 to 23 kg, it is 3.75 ml BD. 23 to 40 kg, it's 5 ml. And more than 40 kg, it is 6.25 ml. Sometimes it is difficult to remember. However, we can put it on our table or in the drawer to remember the doses. Infant, 2 weeks to less than 1 year of age, the dose is 3 milligram per kg twice a day. It comes to 0.25 ml per kg. And the prophylaxis is an OD dose, 2.5 ml OD for less than 15, 3.75 for 15 to 23 kg, 5 ml OD for 23-40 kg, and 6.25 for more than 40 kg OD doses. So we learnt about oseltamivir, its pharmacokinetic, its dose regime. Now let us look at the real case scenario which Dr. Ravi had seen this year and the last year. Over to you, Dr. Ravi.
Yeah, thank you, Dr. Geetan, for nicely elaborating about the influenza virus and its treatment options. So here we will be discussing few of the day-to-day cases which I have seen in my practice, and these were quite illustrative cases, so I included in this presentation. This one was Ishani, 6.5-year female child. She was a resident of Vesu, Surat. The child was immunized for routine childhood vaccination, though she skipped influenza vaccine for this season. The child presented with fever, which was quite high grade, 103 to 104 degree Fahrenheit, with cough and cold for 2 days, throat pain for 1 day, and breathlessness only just few hours before the hospital presentation. There was no significant past history in the child, and there was no history of similar illness in the family members also. But according to mother, there were few cases of cold and cough in her school, which was communicated by her colleagues. Child on examination was well nourished, febrile, with temperature of 104 degree Fahrenheit, mild tachypnea with respiratory rate 42 per minute, mild retraction. There was mild respiratory distress in nutshell. The child was little tachycardic with a heart rate of 150 per minute, blood pressure 90/60, saturation of 93 to 94% on room air. Throat was grossly congested with clear watery nasal discharge. Chest was mild respiratory distress with bilateral crepitations mainly on the basal region, and rest all systemic examination was normal. So we started stabilizing the child and investigated. Routine investigations like CBC showed normal hemogram with hemoglobin of 11.9, TLC of 5,800, mainly polymorphic with normal platelet count. CRP was 6.7. Chest X-ray showed bilateral perihilar opacities in the form of prominent bronchovascular markings. Considering all above finding and a sick child with respiratory distress which was uh, worsening very fast, a respiratory multiplex PCR panel was advised and sent, and it was positive for influenza H1N1 virus. On the course of stay, the child was started immediately on IV fluid and oxygen inhalation with nasal cannula. Oral oseltamivir was added after the influenza report within few hours. Child continued to have high grade fever for the next 24 hours and required repeated paracetamol infusion. After 24 hours, the fever spikes started declining, so child was shifted to oral paracetamol, and respiratory distress also started settling down. And child was gradually weaned off from oxygen without any respiratory distress, and child was continuously maintaining the saturation. At around 72 hours, the child was totally afebrile with no respiratory distress, though some weakness and cough still persisted. At around 72 hours, the child was discharged on oral oseltamivir and SOS cough suppressant. So these childs highlight that there is a rapid progression of the disease in viral illnesses like influenza, and the rapid diagnosis and rapid prompt antiviral therapy can be very rewarding. The second case is a Prishit. He is a 10-year-old male child. He was a known case of seizure disorder, no oral valparin, and there was no episode of seizure in the last more than 1 year. And they had planned for a tapering of valparin doses, but then the child presented with persistent cough for 3 days and simultaneous fever, which was from beginning it was 102 to 103, with profound weakness, body ache, heaviness of the chest. And just before presentation to the hospital, there was one episode of tightening of the upper limb and uprolling of the eyes, which was very transient and only lasting for a few seconds. So child was admitted in emergency department. His weight was 33 kgs, height 137, temperature 101 degree Fahrenheit, pulse 137 per minute, respiratory rate 38 per minute, SpO2 98%, and blood pressure 120/70, and there was no respiratory distress. Child was fully conscious, oriented, no abnormal movements at the time of presentation. Throat was grossly congested, and chest had shown bilateral conducted sounds and significant bronchi, bilateral. CNS and other systemic examination were normal. So we started stabilizing the child and investigating simultaneously. Child had a normal CBC, hemoglobin of 12.5, TLC of 4,900, CRP 18.6 milligram per deciliter, and chest X-ray, as we will show you, it showed bilateral parahilar prominence. Flu panel was suggestive of influenza B. So this is a kind of X-ray which we find most of our flu patient. There is a typical parahilar prominence, and in this child there was quite significant hyperinflation also. So on the course of hospital stay, child was started on IV fluid, IV amoxicillin, amoxiclav, and levosalbutamol nebulization. And oral oseltamivir was added after the report. Child started showing improvement after 24 hours, though nausea, vomiting, and letharginess remained for a couple of days, but there were no further seizures, and fever also declined. And after 3 days of therapy, the child was discharged on oral oseltamivir with supportive treatment. So this case actually suggests us that the child was pretty stable with a seizure disorder and was on verge of tapering the medicine, but because of influenza-like illness, the case was complicated and there was a bout of seizure. So influenza does complicate underlying comorbid conditions. So third case is of the 14-year-old female child. She presented with fever for 6 days. Initial 2 days it was high-grade fever and then decreased in intensity. Child had been traveling to Rajasthan and was taking oral paracetamol on SOS basis. But there was main complaint was increasing cough and severe lethargy. So child was unable to stand. There was lot of dizziness, and child had to be brought in a wheelchair. There was a family history of fever and cough in two of the native relatives. Child was dull looking on admission, febrile with temperature of 101, dehydrated, blood pressure of 90 by 60, respiratory rate of 32 per minute, saturation of 98% on room air, heart rate 146 per minute. There was no respiratory distress. Throat was congested, conjunctiva was also congested, and there were evidence of stomatitis, and chest had shown bilateral fine crepitations without any respiratory distress, and rest of the systemic examination were not remarkable. So we started stabilizing the child immediately and then started investigation. Hemoglobin was 14.2. There were little hemoconcentration as compared to the previous reports. Uh, TLC was 3,400 with 45% neutrophils and platelet of 1,69,000. CRP was normal. Chest X-ray had shown typical bilateral lower zone haziness with prominent bronchovascular markings. So biofire was sent considering this kind of sick child with respiratory presentation, which was suggestive of influenza A H1N1. So once we admitted the child was started on IV fluid, IV ceftriaxone and nebulization, added on to oral oseltamivir, and after rehydration, child showed significant improvement in general condition. And after 36 hours of oseltamivir, child improved dramatically with improvement in fever and respiratory signs, and child was eating well and communicating well, and child was discharged after 3 days on oral medication. So this case highlights the effectiveness of oseltamivir even in the later phases of disease. Generally, it is believed that this drug is effective mainly in the initial phases. Yes, it is correct, but it can also, given an opportunity, it can be used in the later phases of disease also, and it can be quite effective as highlighted in this case. Over to you, Dr. Ketan.
Thank you, Dr. Ravi, for very nicely elaborating the real life case scenarios. To the audience, these are the real life case scenario which Dr. Ravi has already depicted. Early use, complications or comorbid condition getting aggravated, the late use of oseltamivir in influenza illness. In all these three scenarios, we had a wonderful result and child improved within 2 or 3 days. So same way, the infant who is a 2 week old had a fever, cough, cold. One family member is admitted for respiratory infection and there is a family history of cough, cold and fever. Looking to the age factor of 2 weeks, this child is at a high risk of getting serious influenza illness. So it is better to start oseltamivir even without testing in early infancy. This is a known case of nephrotic syndrome who is on steroid, not vaccinated, getting acute respiratory infection with myalgia, fever, cough, cold. If he is fitting into the category A, then also the oseltamivir is justified because he is an immunocompromised child. 9-year-old child, known case of asthma, had a fever, cough, running nose, not very sick. Even is into the A category, we need to start oseltamivir because asthma and influenza, they are a deadly combination. Both aggravate each other. All asthmatic, they are likely to get severe influenza, and all influenza patient, if they are asthmatic, there is a significant trigger into the respiratory distress. So early treatment with oseltamivir is justified in all high-risk category, all immunocompromised patient, even a contact of a patient who is immunocompromised, the prophylaxis is recommended. So oseltamivir is a wonderful drug for walking pneumonia and early onset severe symptoms. There are clinical trials showing benefit of empirical and early use of oseltamivir. This was a prospective study. Data on lower respiratory tract complications and antibiotic use from 3,564 subjects with influenza-like illness. They were enrolled in 10 placebo-controlled double-blind trials of oseltamivir or no other antiviral therapy. It has been found that when the oseltamivir was used, the antibiotic use reduced by 26.7%. Influenza-related complications resulting in antibiotic therapy has reduced to 55%, and hospitalization rate has also reduced up to 59%. So the use of oseltamivir has a significant benefit on other part of the story also. The reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. This was a study on 442 patients. The mean time of starting oseltamivir was 5 days. The patients were divided into less than 2 days, 3 to 7, 8 to 14, and more than 14 days. The response was assessed, and it has been found that if you start oseltamivir early, the chances of getting severe pneumonia or probability of any other severe pneumonia reduce significantly. This has been seen significantly in H1N1 pandemic in 2009. Even patients with a shorter time to oseltamivir administration, they were discharged earlier from the hospital. This graph shows that the number of days of hospitalization were significantly reduced. Those who were started with oseltamivir in less than 2 days, between 3 to 7 days, it is a group 2, and 8 to 14 days is a group 3, where the hospitalization was for 10 to 15 days, and a group 4, when more than 14 days of starting oseltamivir, the hospitalization was almost up to 20 to 30 days. This is about the post-exposure prophylaxis. It is a 10 days recommendation. And for community outbreak or seasonal, it is up to 6 weeks. And in immunocompromised, it is up to 12 weeks. So looking to these all, do we have a standard recommendation? Yes, from WHO, it has been said that empirical treatment is strongly recommended. Treatment should be started as soon as possible. Lab confirmation is not mandatory, and if it is negative, then also treatment is validated. And in high-risk individual who are exposed to a patient with influenza, presumptive treatment is advisable. This has been recommended by Ministry of Health and Family Welfare, Government of India also. In adult with community-acquired pneumonia, when you have a proved case of community-acquired pneumonia, and if you get influenza test positive, should we add on oseltamivir? Yes, it has been recommended that in community-acquired pneumonia, if influenza is positive, if you start with oseltamivir, the chances of getting complication because of CAP or community-acquired pneumonia, or even with influenza, reduces significantly. The duration of treatment also reduces. Duration of hospitalization also reduces. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. It has been recommended by WHO, American Thoracic Society, and Ministry of Health and Family Welfare of India. Thank you so much for patience hearing. Thanks to Dr. Ravi. Over to you, Dr. Jog, sir.
Thank you. Thank you, Ketan and Dr. Ravindra, for giving all the details related to this, you know, naughty, drifty, shifty virus. And now everybody in the audience knows that we can detect influenza from the clinical signs as well as with the help of the laboratory trace if required and manage it by early use of oseltamivir. Dr. Ravi, many times it so happens that there is a child suffering from influenza in the family, and there are some household contacts like the grandfather who is asthmatic, a father who is diabetic, and a mother who is pregnant. So many times it becomes important to take care of these people also. So how do you guide the parents of such a child who has influenza, which is proved by nasopharyngeal swab?
So first of all, we need to take care of the patient itself. So isolating or quarantining the patient is very important because the influenza is such a kind of disease which is spread from the babies to the adults. So primary source is generally the kid who has bought the influenza virus from his peer group or some of his friends, and then and they are very difficult to control. So they keep on touching the surfaces, keep on roaming around in the house. So it's quite difficult. But one thing which is very important is, as far as possible, isolating them and taking precautions of hand hygiene and using handkerchief and maybe mask sometime. Number two, we can offer the patient at the relatives at risk, like elderly relatives or immunocompromised or with some chronic diseases. So we can offer them chemoprophylaxis, as Dr. Ketan has already elaborated in his slides, that we can give 10 days of prophylaxis of oseltamivir once a day, so which will be very effective if started early on the disease course. And then I would even like take a chance that to educate the parents about influenza immunization, which can be advised for the further episodes to any relatives who are elderly or other siblings also.
Thank you. And Dr. Ketan, many times our colleagues are in two minds when they face a child with fever, cough, cold, as to whether they should start with antibiotics or antivirals. So, how would you guide them, keeping in mind rationality of practice at the back of your mind?
So usually the viral respiratory presents with high-grade fever on day 1, 2, then gradually it goes down. Viral would have a watering of eyes, running nose, throat congestion, coughing, and family clustering of the disease, either in the school or in the family. So this is most likely a viral category. And if it fits into the category A, symptomatic treatment is advised and follow up after 2 or 3 days if he is worsening or getting into B or C category. If he is improving, no need of any medication, or on second, third day, if patient is not fine, getting deteriorated, then probably antiviral drug is justified. Antibiotic for classical viral respiratory symptoms is not justified. So clinically, we can differentiate the use of drugs. Thank you, sir.
Thank you. And Dr. Ravi, many times, when we are in a dilemma, we want to prove that influenza is the diagnosis. And for that, the nasopharyngeal swab uh, comes to our help. So, what is your opinion about the sensitivity, the specificity of these tests, which are done to find out the organisms in the throat? And when would you advise it to the parents?
So as was elaborated in this presentation, that influenza investigation generally is reserved for category C type of patient, and not all patient requires to be proven for diagnosis. And whenever there is a confusion in with other respiratory illnesses and the child is sick, we can offer them the PCR test. The one disadvantage of PCR test is though it is very sensitive and specific for influenza virus, but there can be normal commensals also which will be picked up in this test, and we have to carefully uh, evaluate the results because we might end up over treating the patient many times. So we have to, once we take the test, we have to analyze the sample with a pinch of salt.
Okay, so we have now lot of idea about this particular virus, and we have also answered the queries of our delegates. So I must say that you have elaborated on different ABCs. So influenza itself has A, B, and C types. So you have elaborated that. You have elaborated on A, B, and C, the categories of influenza seriousness. Okay. And I must say that A would stand for assessing and deciding the need for antivirals and antibiotics. B would stand for being aware or beware of the danger signs. And C would stand for consulting the pediatrician if required. And I congratulate you for another ABC for being accurate, brief, and clear. With that, just to avoid transmission, as we always say that we have to say namaste, I also, with folded hands, thank all the listeners, delegates, Heteropharma, Ketan, and Ravi for a patient listening, and hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. As usual, your session is amazing. Thanks, Dr. Ketan and Dr. Ravindra, for bringing live cases, which I'm sure will help our participants. And thank you all the doctors who took time from their schedule and attended this webinar. Thanks, Nagadevi, thanks, Samriti, and thanks, sales team of ITRO for super coordination. We can sign off, sir, and we'll join again in some time.
Thank you,
Thank
sir.
you.
Thank you.
Thank you.
Thank you.